This presentation will focus on delirium. The learning objectives for this presentation include defining delirium, discussing the epidemiology across healthcare settings, discussing the pathophysiology, identifying risk factors for the development of delirium, recognizing and diagnosing delirium strategies, and discussing practical treatment strategies once delirium is diagnosed. Our presentation is going to begin with a case study. Our patient is an 84-year-old female who lives at an assisted living facility. She has a history of dementia, atrial fibrillation, breast cancer, and urinary incontinence. She has been admitted to the hospital after a fall and has been vomiting coffee grounds emesis with dark stools. She's oriented on admission to person and situation, but not time and place. At the hospital, she was started on a P-ABI fluids and the Xarelto was held. On the morning of the hospitalization day 2, she began to yell at staff. In the afternoon of hospitalization day 2, she was sleeping quietly for 4 hours. The nursing staff reported poor sleep the night previous due to assessments and the early lab draw. Remember this case as we go through the next few slides. The definition of delirium comes from the DSM-5 manual. According to the DSM-5 manual, the patient must display both disturbance in attention and awareness, and this disturbance needs to develop acutely and fluctuate in severity. In addition to these two criteria, the patient needs to display one of the following. The disturbance cannot be explained by a pre-existing dementia. The disturbance does not occur in the context of coma or reduced level of arousal, or there is evidence of an underlying organic cause. Although our understanding has improved, 2025 research reinforces that we still lack effective pharmacologic treatments for delirium and need more targeted strategies. This highlights the importance of prevention and non-pharmacologic interventions. To highlight some important takeaways from the DSM-5 criteria, there must be a noticeable deficit in attention span and awareness as it relates to your interactions. These deficits are sudden in onset and noticeably fluctuate. The report that you may have is that symptoms occurred over the course of hours, and that the family or staff is reporting that the patient is at baseline one moment, and the next moment they are not. Another important takeaway point is that the underlying dementia of the patient cannot explain the above changes. You, as the provider, must search for an underlying etiology to explain the changes that are occurring within the patient. We know that the occurrence of delirium varies across different settings. This slide lists the epidemiology of delirium in various settings that we see throughout the healthcare continuum. It is important to note that rates of unrecognized delirium remain unchanged over a 15-year span. Despite education on this topic, rates of unrecognized delirium were 55 to 70% in 2000 to 2001 and 60 in 2015. Persistent high rates of unrecognized delirium exist, up to 70%, despite awareness efforts. This updates the older statistics, for example, 2017, and highlights ongoing challenges. Recent studies show that delirium is increasingly recognized across all age groups, not only in older adults. Research published in 2025 highlights that delirium still has substantial knowledge gaps, especially regarding its mechanisms and its presence in younger adult populations. Including this perspective helps us avoid overlooking delirium in patients under age 65. We know there are significant consequences to a diagnosis of delirium. Delirium is expensive and increases healthcare costs for that patient. It is also devastating to patient outcomes. Persistent delirium can occur up to 6 months post-hospital discharge. Delirium independently increases the risk of death at least twofold for a patient. It results in a functional decline with a potential loss of independence, and more than doubles the risk of a nursing home placement. In addition, delirium can cause an increase in the risk of dementia. The pathophysiology of delirium is not completely understood. It is thought to be the final common pathway of multiple mechanisms and can be described as acute brain failure. There are a lot of theories that exist, but the most common theory for delirium is cholinergic deficiency and inflammation. Glial cells, microglia, and astrocytes in neuroinflammation lead to neuronal dysfunction. This builds on the cholinergic and inflammation theories with 2023 to 2025 evidence from biomarker and animal model studies. Newer biomarker research in 2025 proposes that delirium consists of distinct biological endotypes. Markers such as neurofilament light chain and S100B suggest axonal and glial injury, while cytokines and hormonal markers indicate inflammatory and stress-related pathways. This newer framework helps explain why delirium presentations vary so widely among patients. We will first discuss the cholinergic deficiency pathophysiology theory. This theory is supported because medications with strong anticholinergic activity can trigger delirium. However, medications that increase acetylcholine have not shown efficacy in treating or preventing delirium, so it is not possible to say that the cholinergic deficiency is the cause of delirium. There is a simple tool to calculate the cholinergic version of a medication, which is available at the website listed on the slide. Next, we will talk about the inflammation pathway during states of infection. Inflammation white blood cells adhere to the blood-brain barrier and can trigger disruption of the usually tight cell disease adhesion. This disruption allows increased permeability across the blood-brain barrier, increased transport of white blood cells, peripherally released cytokines, and decreased perfusion, and create longer diffusion distances for oxygen. The result of this disruption leads to neuronal ischemia and death. Though this theory is supported by the pathophysiology described, we do know that delirium also occurs in settings outside of those of infection and inflammation. So the inflammation theory alone cannot describe the pathophysiology of delirium. Traditionally, we think of three subtypes of delirium: hyperactive, hypoactive, and mixed. Hypoactive is 50% of the cases. Usually, the hypoactive subtype delirium is missed or under-recognized. The symptoms of hypoactive delirium are decreased alertness, slow speech, lethargy, and apathy. Hyperactive delirium is very easy to recognize and constitutes 25% of the cases. Symptoms of hyperactive subtype of delirium includes heightened arousal, restlessness, wandering, and aggressive behaviors. The mixed subtype is a combination of hyperactive and hypoactive. Recently, the literature has discussed two additional variants. There is a catatonic variant, which is an extreme form of hypoactive delirium, and the excited variant, which is an extreme form of hyperactive delirium, which is usually associated with abuse of some of the medications. The Delirium Subtyping Initiative, DSI, 2023, proposes data-driven subtyping using latent class models, biomarkers, and electrophysiology to identify novel endotypes beyond traditional motor subtypes: hyperactive, hypoactive, mixed. Include emerging research on longitudinal subtype changes and abbreviated tools like the DSS-4 for rapid assessment. This addresses heterogeneity and improves research and treatment targeting. While the classic motor subtypes remain clinically useful, recent evidence proposes biologically defined endotypes based on multimodal biomarkers. This means future classification may integrate physiology rather than behavior alone, helping us personalize treatment strategies. We will now return to our case. Thinking about what you've already learned, what was her subtype of delirium? Going back to what happened with our patient on the second day, we stopped her medication and requested lab draws to be drawn after 8 a.m. to allow the patient to be able to sleep. The resident was also ordered to be able to sleep throughout the night without assessment unless needed. The Foley catheter was removed along with any telemetry monitoring, and the IV was continued, but the fluids were stopped. The patient was also ordered to be out of the room 2 to 3 times a day and to be out of her bed for meals. The family was educated on reorientation of the patient, and reorientation was discussed with the staff as well. As healthcare providers, it is important to recognize the risk factors for the development of delirium. Risk factors are categorized into predisposing and precipitating factors. Predisposing factors are usually inherent and intrinsic to the patient, and precipitating factors are usually extrinsic. Delirium will develop when the combination of these factors crosses a critical threshold. This means that if a patient has more predisposing factors, less precipitating factors are required to tip the patient into delirium. This list here shows the predisposing risk factors for the development of delirium. It's important for a U.S. provider to be aware of these predisposing risk factors and to identify if they are present in your patients. The 2025 APA guideline highlights that establishing a patient's baseline cognitive status is critical when evaluating delirium risk. It also recommends a structured, detailed medication review to identify contributing agents, especially in people with pre-existing cognitive disorders. Here are the risk factors for the development of delirium. Medications will be discussed on future slides. It is important to note that anesthesia and surgery are both risk factors for the development of delirium. For anesthesia, the route isn't as important as the total dose when considering risk factors for surgery. Hip fracture repair as well as cardiac surgery have a higher incidence than post-elective non-cardiac surgeries. These are the medications that are considered to be risk factors for the development of delirium. It's important to note that many patients may be on these medications at their baseline. These medications already put the patient at risk for delirium when you combine them with additional risk factors such as surgery. As seen in the hospital setting, the patient has a higher risk for the development of delirium. Uncontrolled pain, bed rest, and use of physical restraints are significant contributors to delirium. The presence of indwelling devices and acute exacerbations of chronic illnesses, such as COPD or respiratory failure, also increase risk. Acute illnesses like myocardial infarction, stroke, and infections, such as UTI or cholecystitis, are common triggers. Withdrawal from medications or substances can also precipitate delirium. Use the mnemonic delirium to remember common causes. D. Drugs. E. Electrolyte disturbances. L. Lack of drugs. I. Infection. R. Reduced sensory input. I. Intracranial causes. U. Urinary and fecal issues. M. Myocardial and pulmonary conditions. Patients with delirium may show difficulty concentrating, confusion, mood swings, hyperactivity, speech difficulties, poor sleep, reduced short-term memory, incontinence, hallucinations, and delusions. Now we'll give you a chance to test your knowledge. Which symptom is most commonly missed in hypoactive delirium? A. Hallucinations. B. Confusion. C. Lethargy. Or D. Hyperactivity. The correct answer is C. Lethargy. Key history includes onset of symptoms, baseline mental status, level of consciousness, orientation, and symptom fluctuation. Assess distractibility, speech organization, hallucinations, delusions, and recent medication changes. Physical assessment should include vitals, orientation, consciousness level, and system-specific exams. Evaluate mucous membranes, pupils, heart sounds, lung sounds, bowel sounds, muscle strength, and perform mental status and psychiatric evaluations. Diagnostics should be guided by history and physical exam. Common tests include CBC, electrolytes, renal function, urinalysis, liver function tests, EKG, chest X-ray, drug levels, and EEG. New practice guidelines recommend that all at-risk patients undergo regular structured delirium assessments using validated tools such as the CAM or 4AT. This is based on evidence that routine screening significantly reduces missed delirium cases. The confusion assessment method, CAM, has several forms. 3D CAM, quick and effective. CAM ICU, for nonverbal ICU patients. BCAM, for verbal ED patients. CAM-S, assesses severity. FAM-CAM, for home settings. CAM includes 4 features. 1. Acute onset or fluctuating course. 2. Inattention. 3. Disorganized thinking. 4. Altered level of consciousness. Diagnosis requires features 1 and 2 plus either 3 or 4. Other screening tools include 4AT, easy and quick. New DESC, may overemphasize hyperactive delirium. MRAS, lower sensitivity. Delirium Observation Scale, under development. Here is our second polling question. Which tool is most suitable for rapid screening in general wards? A. CAM. B. 4AT. C. New DESC. Or D. MRAS. The correct answer is B. 4AT. The 2025 guideline strongly recommends multi-component non-pharmacologic interventions as the primary management approach. These include sleep optimization, reorientation, mobility support, hydration, and sensory aid use, which collectively reduce both incidence and duration of delirium. Non-pharmacologic treatments focus on prevention, maintain sleep-wake cycles, reorient frequently, minimize noise and distractions, ensure sensory aids are used, provide regular fluids and familiar items. Pharmacologic options include Haldol, Risperdal, Seroquel, and Zyprexa based on agitation level. Discontinue medications once delirium resolves. Updated recommendations advise that antipsychotics be reserved exclusively for patients experiencing severe distress or posing imminent danger to themselves or others. They should not be used to prevent delirium or to shorten its duration. Prevent delirium by maintaining sleep-wake cycles, limiting risky medications, ensuring adequate hydration, and monitoring for infections. Educate families that delirium is usually reversible. Encourage family presence and reorientation. Use medications only when necessary. Remind families not to take patient behavior personally. The resident improved over 3 days. Bleeding source was treated. Due to weakness, she was transitioned to a nursing home for therapy with the goal of returning to assisted living.